All right, so why don't we get started? Thank you all for joining us on this Zoom webinar. It's a little new to all of us, this kind of COVID world we're living in, so we'll try doing it this way. Usually I like to have in-person kind of talks, but that's been on hold. For those of you who don't know me, my name is Dr. Rakala. I'm a double board certified physician here at Orthopedic Associates. And I'm going to be talking today about venous disease. It's a disease that's quite prevalent in the population, but the symptoms and signs of it are not so widely known. So I think it's good that you joined to learn a little bit more about this. So we'll start the slides now. So, we'll be starting to try to understand what is venous disease, what are some of the signs and symptoms, and what are some of the treatment options we have here at Orthopedic Associates for this disease. Next slide. Oh, actually, just a little overview of the organization of this Zoom chat. So I'll do probably like a 10-15 minute presentation on the disease. Some of the treatments and things like that. And then we'll do like a 20-minute, half an hour Q&A session at the end. So if you guys have any questions, you guys can definitely write in or do a talk in, and we'll try to get to all of those. So some of the signs or symptoms that patients do come to me with are saying that they have trouble specifically at the end of the day with their legs swelling, with pain. I see a lot of my patients are nurses, after a long shift, they just notice that their legs are aching and they just have trouble getting comfortable, and they're not exactly sure why that is. Next slide. Again, restlessness, difficulty getting comfortable. These are some of the signs and symptoms of having this venous disease. Next slide. Some other terms for it are chronic venous insufficiency. These are recognized medical diagnoses. It's really the symptoms that most people don't attribute to this problem. They're just kind of sometimes vague, and people are not sure. Their legs are swelled at the end of the day. They have pain, things like this. Next slide. Some of the risk factors that people who do develop this disease have are, typically you see patients, 35, 40. A lot of times it's very common in women. There does seem to be a large family genetic kind of predisposition to this, aunts, grandmothers, mothers having similar issues. Some other risk factors, they're not as well understood, but are definitely seen, are occupations that require you to be standing for a prolonged period of time. Weight gain can also cause that. Definitely see it a lot after pregnancy. Smoking too can be a factor as well. Next slide. Typically, people will kind of associate this disease when they start thinking, of like spider veins. Is this a cosmetic type of issue? And it's not. Spider veins may be a sign of more underlying issues. So if you do have those, we would probably recommend getting a further evaluation to see, what else is going on. But again, a lot of those symptoms that I was discussing before are some of the signs that maybe something else is going on. Next slide, please. As you can see in this slide, venous reflux disease is quite prevalent in the population, but it's not so widely diagnosed as we've been talking about. You know, these other diseases are definitely much more understood or in the population, so people seek treatment for them much more than actually this disease. Next slide. So some of the reasons why this occurs is we have our nice heart pumping our blood down to all of our extremities, you know, our legs. We don't have a heart down there pumping the blood back up. So how does the blood get back up from our feet to our heart? That's where we have these nice veins that are designed. They have an elasticity and they have valves, and the combination of muscles pumping the blood up, the valves opening then closing, allows the blood to kind of work its way back up like a lever type of system to the heart. Unfortunately, some of that elasticity, if you think of like tube socks or things like that, that after a while the stretch is just gone and they're just kind of fall back down, that's what kind of happens to the veins. They kind of expand and the valves stop working. They're not touching, so the seal is not there to kind of block the blood from going up and then coming back down. When the blood comes back down or refluxes, then the main highways, the traffic or the blood goes to the side roads, and that's where you start getting these side roads or these, you know, varicose veins that get expanded. You start getting the spider veins, and the superficial system gets overwhelmed because it's not designed to have that much traffic, so to speak, or blood kind of pooling in that area. Next slide. This is a really good slide. So you can kind of see some of the progression of this type of illness. So people initially, you know, may have some spider veins, then kind of progress to varicose veins, swelling. Once the blood starts to really pool in the legs, you start to get some skin color changes as the blood actually kind of changes the color of the skin. Eventually, you'll start getting some cracking, sores, but those are more of the visual. So we've all seen, you know, patients or family members or ourselves who have some of these types of visuals. But some of the symptoms are really where I find a lot of patients are not sure what they have, and we're able to actually help them, and they didn't even know what was going on. But like heaviness, burning in the legs, aching, fatigue, cramping, restlessness, you know, are things that I hear from patients and are just not sure why they have them. I also take care of a lot of patients with back problems. They think, okay, is this sciatica? I have diabetes, is this neuropathy? And it turns out that those are not the cause. And then they're kind of left wondering, okay, why do I still have these symptoms when my A1C is well controlled? My back is good, I'm doing my exercises for that. What's going on? Why am I still having these symptoms? And these symptoms, especially, you know, some of the pain, cramping, fatigue, can really limit you doing exercises and activities that would really help some of the other issues that you may be having. Next slide. And these are kind of the stages of the disease where we're really trying to avoid. I'm trying to hopefully educate and get people in before it becomes this stage. So if it's not treated, eventually the skin will start to break down, and you'll have these ulcers in the legs that just won't heal. They're very hard to get healed. You have to go to the wound clinic, and it becomes very difficult. So if we can avoid patients kind of progressing to this point, it's obviously much better. Next slide. Again, the slide just shows like the prevalence of when people have ulcers in their legs, that it's likely, coming from this source. Next slide. So if you have some of those symptoms, or you have some of those visuals with the swelling or the varicose veins, how do we figure out if you actually have this disease or not? And it's very easily diagnosed. In our office, we have ultrasound techs who basically screen the superficial and deep system, but really the superficial system to check the veins to see, is the blood moving efficiently from the lower extremities back up to the heart, or is it refluxing back down? have the veins dilated or become too big that the valves are not touching properly anymore, and that's causing the blood to pool and go to the side roads or side veins. So the ultrasound is done in the office. It's about a 30-minute type of test, not invasive, just with the ultrasound machine, and it gives us a lot of useful information. Next slide. And then after we get that ultrasound test, we can, usually I see my patients back. These days I've been doing telemedicine kind of appointments, but in the pre-COVID days, I'd have you come in and then we could talk about the results. And basically, depending on which veins aren't working properly, we can come up with like a treatment plan. Next slide. Some of the treatments, usually patients I've seen have already tried some form of these conservative treatments already, but if we haven't, those are things that we definitely can start with. There's some simple things that can have some benefit. So we recommend doing, at the end of the day, whenever your legs feel really uncomfortable, you can do leg elevation, where basically recommend you lay down, make sure your toes are above your nose, and that will allow gravity to help do some of the work to bring the blood back up to the heart. Other things that we do, some anti-inflammatory medications can help with some of the symptoms. Also some calf exercises. I'm not sure if any of you have done long airline flights. They usually recommend you kind of pump your calves up and down, kind of bring your ankles up and down. That helps use the muscles in the legs to pump the blood back up to the heart. Other things that we recommend are compression stockings. Usually patients try them. Unfortunately, they can be a little uncomfortable. They can be difficult to put on. But we do recommend definitely trying those, first. Unfortunately, if those are not effective enough, then, we have some other treatment options. Next slide, please. So the treatment options that we have now, we've actually progressed. In the olden days, we used to do venous stripping, where basically whichever vein or whatever veins were not working properly, we would actually make a bunch of little incisions and surgically remove those veins. It was a very painful kind of procedure. There's a lot of little scarring that was there, and the recovery was actually quite involved. You were, you couldn't travel for, several weeks. You were, kind of almost in bed rest for a bit. So luckily, we've gotten much more advanced in our treatment options. So the things that we're doing here at Orthopedics is we do the closure fast system, where basically I access the vein with a needle that's not working, and I can use some heat to close that vein. Another option that we do here is the Venous seal system, which is we access the vein again with a needle, but instead of using heat to close the vein, I use basically like super glue to close it, glue it closed. Other options in that middle category there are there are some options with foam that can close the vein as well. Again, you're accessing the vein with a needle. So these are all needle-based procedures. The nice thing with all of these procedures is they're done in the office. They take about 45 minutes. You go home with a dressing. You're on your feet the same day. You're back to work the next day. So there's no big recovery from these procedures as there was with the old venous stripping. So the patients that we've done this for, some patients are a little scared initially. They're like, oh, this sounds very painful or uncomfortable. So, I do sometimes give them some relaxing medication if we have to, but I've never had a patient who I've had to give relaxing medication for the first procedure have to use it for the second procedure. Usually after they see that, how minimally invasive it is and how it's not too uncomfortable, patients have done very well with it and have really not needed any like pain medication or anything like that, afterwards. Next slide, please. So, just a little summary. The treatment, is done in the office. It's pretty easy. It's minimally invasive. It's done with the ultrasound and needles. It's not a cosmetic treatment. I mean, there are some cosmetic benefits to this, but that's not really what we're going for. We can always talk about that stuff later, but really you want to treat the disease so that way you can help prevent the progression. Also, it really helps with all those symptoms. Sometimes they're vague and you're not really sure what those symptoms are, but sometimes they're really debilitating. The cramping, you can't walk past or stand for extended period of times without really having these symptoms. The nice thing is these are all covered by insurances, and the scans, are done in our office, and relatively quickly. And the patients we've been doing here have been doing fantastic. Everyone's been really happy with the improvement. Even just last week we had a patient who we only did one of his 4 or 5 procedures that he needs done, and he was ecstatic. He was like, "Oh, couldn't wait to come get the other ones," because he could already see and feel such a drastic difference in his leg, and he was just so happy. So I guess in summary, I mean, if you feel like you have any of these signs or symptoms, or you're not sure, you can come see me anytime, and we can always get the ultrasound test done and see what's going on, and then depending on that, we can always come up with a treatment plan. Next slide. All right, I think that's the end. So why don't we at this point open it up to some questions. I'm just going to check the chat and see. Yeah, I'm just getting some feedback from one of my patients who is just writing to me that she's very happy with the diagnosis, and has been kind of struggling trying to find a reason why she was having the symptoms, and she's already had she's having a procedure next week, and she's very excited. So I'm glad to hear that. Any other comments or questions or concerns? All right, so looks like I've got a list of some questions here. So I'm just kind of gonna go through, I'm gonna read them out loud and then just kind of discuss the answer out loud. So one question is, are deep thigh pain, leg cramps a concern for clots, heart problems? That's a very good question. The deep thigh pain, cramps are definitely a concern for circulation issues. The nice thing is if you have those symptoms, we would do an ultrasound scan to see. With the scan, we're also assessing, is there clots in the deep venous system or the superficial system? And that will also help determine what the next course of treatment is. Some of those symptoms can correlate with clots, some of them don't. Some of the disease itself can cause superficial clots, which are treatable with these types of treatments that we discussed. Another question we got, on average, how long is the recovery time? That's the great thing with these types of minimally invasive procedures. There's no real recovery time. You're on your feet the same day. We have a dressing in place for 24 hours. But you're back on your feet the next day and doing usual activities. So there's no bed rest or avoiding all activities. You have to take off from work or anything like that. Does this increase your chances for DVT? I'm assuming the question is, does the disease, the venous reflux, increase your chances of a DVT? So DVT is a deep venous thrombosis. The disease doesn't increase your risk of a deep venous thrombosis. It does increase your risk for superficial venous thrombosis, because the superficial system, the blood is not coming back up in an efficient manner. So it's pooling and then starts to aggregate. So that is part of the disease process, that you'll get superficial clots. When we do the ultrasound scan, we're always checking the deep system to make sure that's working properly, because that's the system that we're going to be pushing the blood to. So we want to make sure that there's no clot there or anything like that, because if that's not working, then we need the superficial system to stay open. So that's a very good question. Great, I think we have a hand raised for a voice question, so why don't we start with that. Terry?
Yeah, can you hear me?
I can. How are you?
Oh, that's funny, because I lost you on the screen, which is too funny.
Oh, okay. Well,
sorry about that.
That's okay.
I wanted to know, once the procedure is done, can it return in terms of the veins having a problem again?
So not those veins. So once the procedure is done, the vein that is treated will effectively die off and be reabsorbed by the body. So those veins that are treated won't be there. Now, down the road, there are other veins that can pop up, if the deep system is not efficiently handling the flow. Those are sometimes called perforator veins, or maybe associated veins that can occur. So usually what we do is, once we've done the procedures, we just recommend that the patients maybe check in, a year or so later, and if they're having any other issues, just to let us know, and we can do another scan and see if anything else has come up. But the veins itself that are treated, no, they don't come back.
The other question is, I remember from pregnancy, there, veins starting all the way up in the groin as the baby grew bigger and bigger, and then all the way down through the ankles. How do you know where the procedure should be? What determines that?
So that's a great question. So the way we determine that is with the ultrasound scan. So the ultrasound helps us measure the size of the veins and if there's reflux. And depending on that determines whether we should treat that vein or not treat that vein. And then when we're doing the procedures, we are visualizing the veins that should be treated with the ultrasound, and that helps determine exactly where we should be treating them and where we should enter the vein to start the treatment.
And then the last question is, during pregnancy, for many of us, the veins do pop. They do reduce and relax after birth sometimes. When is the appropriate time to say, hey, maybe we ought to visit you because this could be the start of a problem? Because you said come in early, not late.
Well, yes, definitely. But as far as pregnancy goes, that's also a great question. See, pregnancy is, in theory, a temporary state. So I wouldn't treat anyone who is pregnant, or I probably wouldn't even treat anyone who is planning on having more pregnancies, within the next, year or so. I would probably recommend waiting until after pregnancy, because the vast majority of the issues with the veins at that time is a fluid overload type of problem, along with the baby pushing on the areas where the blood will return back up. So it's kind of a false positive, so to speak. So I wouldn't recommend treating that. Now, let's say someone's 35, they've finished having all their kids, and unfortunately some of those symptoms are still occurring. They're still getting swelling, they're still having pain. Then I would recommend having a scan and see what's going on, because sometimes being pregnant and that increased volume of blood, along with the return area in the abdomen being compressed with the baby, can actually cause the veins to stretch out. And again, once they get stretched, sometimes, depending on genetics, the elasticity isn't as strong to kind of allow the vein to return back to its normal size and have those valves working again.
Okay, thank you very much.
You're welcome. Thanks for joining us. All right, so I'm going to answer a couple more questions on the Q&A part. So, great question. How does the closing down of a vein make things better? Does the blood have to find an alternative route? It does. And how it makes it better is we are closing the veins that aren't working and shunting the blood to the veins that are working. So the superficial system, if that's not working, we can close that, and that pushes the blood to the deeper system, which is working. And then by allowing the blood to efficiently return back up to the heart instead of getting trapped in the legs, the symptoms get better, and then the disease doesn't progress, with the skin changes and then eventually getting ulcers and things like that. So yes, we do close the superficial system and get the blood going to the veins that are working. We've got some patients with questions about specific symptoms. Yes, sometimes heaviness in legs can be a sign of this issue. Difficulty with standing, walking for extended period of times, being trouble with running. Those definitely can be signs of this disease. Again, the best way to figure that out would be with an ultrasound scan. I am getting some questions about patients who've had venous stripping in the past. Can they get these new procedures? Yes. Like I said, the venous stripping and even these procedures, they remove the veins that aren't working at the time. There are other superficial veins in our system that also can deteriorate over time, since it's the same genetic and social kind of factors that were affecting the original veins. So again, I would recommend we do a scan and see what's going on. But if there are other veins that have become symptomatic and are having the reflux, and the insufficiency, they can definitely be treated. I also have a question about laser surgery. So I'm thinking this is implying to the laser treatment for the veins. The laser treatment for the veins is another way of heating up, causing heat, to use that to close the vein that isn't working. I don't like the laser personally because it's a little bit harder to control exactly where the heat is going and what area you're treating of the vein. The nice thing with the heat treatment I use, it's radio frequency, and it's a catheter that's inserted through a needle into the vein. And as I'm pulling back, it heats up a small portion of that catheter. So I know exactly where I'm treating and how much of the vein I'm treating. Whereas with a laser, it's heating up the blood and it's treating an area, but it's hard to control how far up the vein you're actually treating. So, I don't like the laser treatment. If I was going to use the heat treatment, I would use the radio frequency. Question: is swelling in both legs a symptom? It could be a symptom. It could also be a symptom of other issues as well. If there's any, uncontrolled hypertension, if there's other issues, that can also cause swelling, but swelling can be a symptom of this issue as well. Again, another question about having surgeries and other vein treatments. We do have success with these new treatments. I have many patients who have undergone some of the older procedures, the venous stripping, and we're getting really great results with this. Again, some of the veins, the other veins that were not symptomatic before can become symptomatic over the years, and you can treat them with these newer procedures. We get some questions on the treatments. What are they called? So there's the two main ones that we do here at orthopedics. One is called closure fast, and that's the one where we use the radio frequency heat to close the vein. And another treatment we do is called Venous seal, where we use glue to close the vein. And another question with that as well is how many treatments per vein? There's one treatment per vein, and usually that one treatment is what closes closes that vein, but there are multiple veins that sometimes need to be treated in the same leg to get the full benefit. I had a question about Medicare, a couple questions about Medicare and coverage. These are covered, both of these treatments are all covered by the insurances, both Medicare and commercial. So we're going to take another voice question as well. I think Judith is going to come on.
Hi.
Hi, Judith. How are you?
I'm fine. I've had varicose veins for a very long time. It's kind of inherited. My family has them. Sometimes they're so painful, I can't sleep. The back of my knees, the veins are so big, they almost look black and blue.
Yep.
Is that treatable?
That is treatable. That is treatable, and I would recommend getting that treated before it progresses even more. Yeah, unfortunately, you know, it does have a high genetic predisposition, this disease, and I do see a lot of family members. I did have I had one family where it was the mother, the father, the son, and the daughter-in-law were all my patients at the same time. So, you know, it does run in families, so to speak. But if it's bothering you that much, it definitely should be treated. You know, the symptoms are the main thing that we wanna treat. Of course, we want our legs to look better and all of that, but that's, you know, not really what we're targeting here. It's really, we want to get the symptoms under control. If it's affecting how you sleep, I'm sure that has a drastic effect on your quality of life. So I definitely would recommend coming in for treatment. We'll start with the scan and see what's going on, and then come up with a plan.
Okay, is Poughkeepsie, I live in Gardner Pine Bush. Is the Poughkeepsie office the closest one, or do you do it in Kingston as well?
We don't do it in Kingston yet. Poughkeepsie is the office where we are.
Okay. I mean, both Kingston and Poughkeepsie are about the same distance, so I'll
Okay.
contact.
Very good. I look forward to seeing you soon then. Thanks for your question.
Okay.
All right. Take care. I have another couple questions also on the Q&A typed in. So question is, how long would you want to try compression stockings before moving on? Usually we recommend, you know, 3 months. If 3 months of conservative treatments haven't really gotten you to a good point and it's still bothering you, then I would, you know, recommend getting more aggressive. And then another question, how many veins do you do per procedure? Typically, it's 1 vein per procedure. There are some of these smaller veins that can cause issues called perforating veins. If there's a few of those in a small area, let's say you have 2 or 3 of those in the calf, we can treat multiples in the same time. It's really kind of dependent on the specific pathology that you have. And then obviously we try to make it so that way, you know, you're not coming in more than needed. So it'll be a discussion as to what's going on and how we can most efficiently do the treatments. We did have a question about embolus and heart attack. So when you do the procedures, the one thing that you are always worried about is this causing a clot? And if it is, where would that clot go? So it's a good question. So the way we you know, kind of monitor that is during the procedure. Again, we're using ultrasound, so we can check the junction where the superficial system and the deep system meet. So we check the junction during the procedure, make sure that there's no clot or anything there. And then after all of our procedures, within 48 to 72 hours, we do a post-procedure scan. And that scan is to check the vein that was treated, make sure it looks like it's nicely closed. And then we check the deep system and the junction to make sure there's no clots in those areas. So that's a good question, but yeah, that is something that you want to make sure is done and looked for and treated if needed. I got a question on how long has the new procedure been done? These newer procedures have been done for years. The question was also about compression stockings, and they can be challenging. That is very true. Compression stockings, they can be uncomfortable because by the nature they have to have a compression amount in there to help force the blood to kind of come back up. So it can be difficult. I do have a lot of elderly patients who do have trouble with, the arthritis in their hands and being able to get the compression stockings up. Also in the summertime, they can be very, very hot and constricting, and then they get sweaty and they get hard to put on. So yeah, I do recommend always trying them, but there are definitely many reasons why they're not the best option. So, those are discussions that we can have together, especially if most of the patients I see have already tried some form of compression stockings. I treat a lot of nurses with this issue, and they always have tried compression stocks and socks and different things, and don't seem to be getting good enough results. So, those are things we can definitely talk about if you're having issues with the conservative treatments. Again, there are other options that we can help you with these newer type procedures. What determines how many procedures you need? So that would be the ultrasound exam. So like I said, they do check the superficial system, and then depending on the size of the veins and how much reflux there is, that will determine whether we need to treat that now, or is that something we can just keep an eye on. And I think had several patients asking, or several people here in the chat asking questions about they've already had some procedures, but they're still having some issues in the area. That likely might be the answer to that, is that you may have had some other veins in the area that were taken care of, but the other ones were not, or they were not to the level that needed treatment yet. So again, that's why I like to usually follow up maybe like a year and a half later to see what else is going on. Question about where am I located? So I do the procedures, and the ultrasound scan is done here in our Poughkeepsie office near the mall. I also go to our New Windsor office. I see patients there, and I also see patients in our Fishkill office. So I can see you guys at those offices if that's closer and more convenient for you. And then we would set up, the diagnostic scan and the treatments up in our Poughkeepsie office. Question about which treatment we decide to use. So, typically, like I said in the presentation, I usually do either the one where we use a little bit of heat to close the vein, or the glue. Currently, Medicare covers the glue procedure. The commercial insurances are slowly coming on board. So, sometimes insurance does have to dictate our treatment option in terms of which one would we do. Now, my Medicare patients, I usually recommend one or the other depending on the length of the vein that needs to be treated, and a few other factors, including patient preference. Some people, like the idea of, I would rather not have to try the glue, or I would rather use the heat. So, those are things that we can discuss together. But my results from both of them are pretty equivocal. I haven't really seen any issues with either one. The only real difference I would have to say is when we do the procedure for the heat, I do have to surround the vein with something that's called tumescent, which is mostly numbing medication and fluid. And basically that just isolates the vein away from the rest of the tissue. So when we heat it up, it doesn't cause any issues anywhere else. So that's the only real big difference. But the access to the vein is still done with the needle, and the recovery is very similar. I got a question about the ultrasound scans. So the usual tests that they do in hospitals are not specifically for this type of issue. Usually they're just scanning the deep venous system to check for clots when there's a lot of pooling and swelling and things like that. So the hospitals and things like that are not routinely checking for the superficial venous disease that we're discussing here. So that's why I recommend patients, even if they've had scans at the hospital, to get scanned with our technician, because again, they're looking at the deep system for clots, and they're not measuring reflux and checking the superficial vein diameters, and that really is what we use to determine whether we should proceed with treatment or not. A question, is radiofrequency procedure heat like the old laser procedure? It is heat, they're both heat, correct. But the laser procedure, like I was saying, is a little bit harder to control exactly where you're treating in the vein, because in the laser procedure, just heating up the blood and letting it kind of go to a certain area, but it's hard to control where the blood is actually traveling. The nice thing with the radiofrequency procedure is it's done with a catheter, and that catheter, we know exactly the length of where the heat will be, and as we're pulling back, we're closing certain sections in a structured manner. So I feel it's a much better procedure, and it's better controlled, and helps avoid some of the other issues that can arise with some of these other types of procedures, such as clotting and things like that. It's much less of a chance of having that issue with this type of procedure. Question, the relationship between spider veins and varicose veins. Spider veins are usually the smaller of the superficial venous system. They're feeding more of the even higher superficial area. Those are usually some of the things that people notice first. It's not, you can have spider veins without having more of the reflux or venous insufficiency, but typically when you start to see that, it just triggers in your head that, okay, well, maybe there is something more going on, or maybe it hasn't progressed yet to the other ones. But typically in the spectrum, usually you start to see spider veins, then the varicose veins come, and basically what it's happening is the main highways in the superficial venous system are backing up, so the traffic or blood has to go to the side roads, just like if the highways close, the side roads get backed up, and they're not used to having all that traffic, and that's where you start to see those changes with the spider veins and the varicose veins. All right, so I would like to thank you all for joining me remotely through this Zoom conference. Thanks for taking your time, and hopefully this was educational. Hopefully if you have any of these symptoms or know family members or friends, feel free to reach out to me. I'm getting really great results with these treatments, and I'm really happy that we're able to offer this to the community. I've had many patients who we're going to Connecticut to get treatment and things like that. So I think it's nice to offer this in our Hudson Valley area. My associate David will be in touch if you guys have any other issues or questions. Down the road, I would love to maybe do one of these conferences in person and get to meet you all in person. But until then, everyone stay safe. And again, thank you for your time.